All right, welcome everyone. We'd like to welcome you to this, it's an online presentation as well as an in-person one. We've got a small contingent here and we've got about 50 people online. So again, thank you for coming to our Lunch and Learn seminar. Today we're going to discuss vestibular therapy, and this is in representation or in recognition of Kinesiology Week in BC and across the country. So we hope you all enjoy the presentation. And I'm going to introduce to Farron here, who's a kinesiologist and a physical therapist. And I'm going to let Farron take over. Thank you.
Thanks a lot, Daryl. And thanks a lot to the BCAK and the BPK department for inviting me out today. And it's good to be back up on the hill after a number of years. It's a little different being in front of the class instead of at the back of the class. But in any case, today we're going to be talking a little bit about vestibular dysfunction, and the talk's going to be about 45 minutes long, and then we'll save some time at the end, and we'll do about 10 or 15 minutes if there's any questions at the end. So yeah, so we'll go ahead and start the talk here. So first, a little bit about me. So I started up here at SFU and did my kin degree in 2008, and after that worked for a few years as a kinesiologist, and then continued my education at UBC doing my physio degree. And that's kind of where I started to develop a bit of an interest in vestibular rehab and vestibular therapy. So as a student, I was exposed to working in some different neural rehab settings and in acute and outpatient wards, and started seeing some clients that had vestibular issues, and as well as some of our research in the program at the time was on postural control, balance, things like that. And so currently I work in an orthopedic clinic out in Maple Ridge called Golden Ears Physio, and about 15% of my practice is in vestibular therapy. So I was fortunate enough to take a few courses in vestibular therapy. A local physio, Nicole Sarah, did her degree her PhD in vestibular therapy, and I also took a course with Bridget Wallace, who's a physio out of the US that works a lot with vestibular issues and concussions. So that's sort of where my training comes from. But today, what I wanted to try and discuss was a little bit of an overview of the anatomy of the vestibular system, as well as discussing why some of the causes of vertigo and dizziness as it relates to the actual vestibular system itself, some of the specific symptoms and triggers that can cause vestibular dysfunction, and also when it's appropriate to refer on to a vestibular therapist, when necessary. And then finally, sort of how that can affect you as a practicing kinesiologist when you're dealing with patients that might be concurrently being seen by a vestibular therapist. Now, the purpose of the lecture today isn't necessarily to train you or to make you competent to do a vestibular assessment or treatment in that regard, because this type of treatment and assessment usually requires some more advanced training. We're looking at things that involve like cervical stability and looking at medical status, and even the coursework itself is typically only available to physiotherapists, physicians, stuff like that. So my real intent for today is to just inform you as a kinesiologist about how you can identify potential vestibular patients based on sort of what they might be telling you in the setting that you're working in, and then where you can refer these individuals if you're thinking that there's something going on that sounds like a vestibular issue, and then how that can affect you as a kinesiologist, and how your treatment might be affected based on what the client might be given from a vestibular therapist. So first of all, what is vestibular therapy? So essentially we're looking at assessing and treatment of some dysfunction that's arising from the vestibular system or the inner ear itself, or things that might be related to a central cause, so maybe more of a neurological condition that could be causing these types of symptoms. And so often people will describe these symptoms of vertigo or dizziness. Maybe there's some visual changes that could be occurring. And there's a whole host, there's a whole gamut of other symptoms that might occur, but when people are describing what's happening to them, they may not be clear. So, they say, well, I have vertigo. Well, what I consider vertigo and what's typically seen is that's that sensation of the person finds that the world is spinning or something is spinning. Versus dizziness is kind of more of a broad term that might involve, feeling imbalance or off balance. They might just kind of feel off center all the time. They might be lightheaded, right? So a lot of the tasks that we're involved with is trying to determine what exactly is the person discussing, and how does that affect maybe the pathology. So you have a client and they say, I'm dizzy. So what? What does that mean? And why should we care? Well, we should care because we know that about 35% of the population will experience some sort of vestibular issue in their lives, the number one cause being BPPV, which I'll talk about in a little bit. And we know that dizziness itself can lead to things like falls and a lot of the secondary complications. So things like a hip fracture, wrist fracture, and hip fracture especially can be quite devastating to someone and can cause long-term stays in the hospital and even things like death. So we need to be aware of that, and we know that studies have shown people with vestibular dysfunction have a much, much higher risk, 12 times more risk of being in a fall. And even if we take falls out of that, people just feel generally awful when they're going through some vestibular dysfunction, and we know that there's higher incidences of sick leave. People stop doing their daily activities and things that they want to do, and some of them don't even want to leave their house because they're feeling so poor. So it can really affect someone's life. So in order to understand the vestibular dysfunction itself, we have to have a good understanding of the anatomy. So our vestibular system is essentially our inner ear, and so that's located in the area of the petrous portion of the temporal bone. And we have two components. We have the vestibular apparatus as well as the vestibular cochlear nerve, which will travel through the internal auditory meatus. So if we're looking at a side view of that, what does that look like? If we have the ear out to one area, we're really focused in on this area sort of past the middle ear and into the inner ear. And so there's a bony area that's cut out, that we refer to as the bony labyrinth. And that contains paralymphatic fluid. And the area that we're most concerned about is these little blue areas that make up the membranous labyrinth, okay? And the main areas that we're looking at are the semicircular canals, as well as these components here called the utricle and the saccule, okay? And each of these give information on how we move our head and how we accelerate and decelerate in space, okay? And they all have connections to the vestibular nerve. Now, it's interesting to note that we also have the cochlea that will be located within the inner ear, and this provides information on our hearing. And so the vestibular nerve and the cochlear nerve travel together, and it's important based on some of the symptoms that people will report, okay? So going back to the semicircular canals and the utricle and the saccule, they're providing different types of information. So our semicircular canals, they provide input directly to our visual control nuclei and affect visual fixation based on how we're moving our head in angular acceleration. So if you're turning your head left to right, up and down, side to side, you're getting information from the semicircular canals, and there's three of them. There's the anterior canal, the posterior canal, and the horizontal canal. And this gives us kind of a 3D awareness of where we are in space. On the other hand, the utricle and the saccule gives us specific information on linear acceleration. So the utricle lies in more of a horizontal plane, and so it's going to give us information on horizontal movements. So sort of more of a forwards, backwards. You can imagine if you're in a car, the stop and go movement. Versus the saccule lie more in a vertical plane and gives us information on vertical movement. So if you're in an elevator going up and down, that sort of sensation of where you are in space. Now, each of those areas have functional sensory organs that give us feedback. So in the semicircular canal, we have these components called cristae, and they're made up of a hair cell that connects down to the nerve itself, and then a cupula. And this is kind of like a piece of kelp floating in the ocean. So it's based on fluid movement. So in this picture, we have the individual that's moving themselves to the right, and there's a relative movement of fluid to the left, which causes a depolarization of the nerve when these hair cells moved in one direction. So it's movement-based. In the utricle and the saccule, our functional unit is called the macula, and it's more so affected by gravity. It's gravity-based. And so what we have is we have these otoliths, which we'll talk about later. These are the sort of the crystals in the inner ear that some people will talk about. And they act as weights kind of on this jelly-like otolithic membrane, and they weigh down that membrane, and as we move our head into different orientations, the gravity itself will pull on the hair cells and cause a depolarization. And so these are important with how the information gets sent to our brain. So we're moving our head back and forth, up and down, side to sides, acceleration, deceleration, and all this information is being picked up by the vestibular nerve, different branches of the vestibular nerve, traveling through the skull and connecting into the brainstem itself. And this is where it branches out. And so there's a variety of inputs that are occurring as we enter the brainstem. So first of all, the vestibular nerve will send down descending fibers down from the vestibular nucleus down into the vestibulospinal tract. Okay, and this is allowing excitation of the posterior extensor musculature and allowing for a lot of our postural control. We also have nerves going in an ascending direction, so they're going upwards. And so we have connections that are going to the medial longitudinal fasciculus and then branching to a lot of our visual centers, and visual nuclei, so the abducens, the trochlear and the ocular motor nerves, which control our eyes, as well as connections into the cerebellum itself. And so these are going to be providing that sort of that fine-tuning of and coordination of our postural control and our ocular movements. And then finally, there's connections that are actually going to the higher centers of the brain into the cerebral cortex via the thalamus. So given sort of the basic anatomy that we're talking about here, it shouldn't be surprising that when we look at the function of the vestibular system, it is going to be responsible for things like gaze stability, so being able to keep our eyes fixed on a point while we move our head around. It's going to be responsible for balance, postural control, and then that idea of proprioception, or knowing where we are in space. So now when we look at difficulties with dizziness, of course there can be problems from the vestibular system, but it's important to realize that there's a whole host of other causes that could cause vestibular problems can cause dizziness as well. So I just wanted to kind of highlight some of those. So, there's a number of things: cardiovascular issues, neurological conditions, visual, these are all things that could be affected. So it's not that, someone who says that they're dizziness, you can right away jump to think, okay, this is a vestibular issue. cardiovascular, is there some sort of ischemic event, a lack of oxygen that could be causing these sort of difficulties? Neurologically, do they have a history of stroke or MS, something that could be affecting them? The visual systems, are we seeing, something as simple as a change in their prescription or new glasses can cause issues around dizziness? Psychogenic, people with anxiety disorders, stress, panic attacks, we can get these types of dizzy symptoms, so it might not have anything related to the vestibular system itself. Different medical conditions, so diabetes is a great example. Long-term diabetics have neuropathy. They can't actually feel what's going on in their feet, so they say, well, I feel off balance, imbalance. You're going, oh, I just saw this vestibular talk, maybe, well, it could be something else, something they should definitely, get looked at, but there's a number of causes. And then, of course, medications. Every medication you see almost these days, one of the side effects could be, dizziness or blurred vision. There could be a number of side effects of medications. So, it's not as simple as attributing everything to a vestibular cause, but there definitely are vestibular causes. So we, as vestibular therapists, we will roughly break them down into sort of three types, just to understand them a little bit better. So the first thing is a mechanical issue, and so specifically looking at issues within the inner ear and specifically in the semicircular canals. And typically we're looking at BPPV, which we'll talk about if there's some sort of mechanical issue with the crystals getting where they shouldn't be in the inner ear. The second area that we look at is more of a peripheral nerve type injury, so where the membranous labyrinth or the vestibular nerve can be affected, causing these type of dizzy symptoms. And then finally, the other place that it could be coming from is more of a central issue. So this is more to the brain, the brainstem, central causes in the nervous system. Now, just, I also have to mention that, if we take all that out of the mix as well, you can still get contributions from the neck itself, and they'll typically refer to that as cervicogenic dizziness. And so a lot of the people that may be out there working with people post-car accident or injury of the neck, some of the pain and dysfunction that can be coming from the neck itself can also cause some of these dizzy symptoms. So, the more I'm talking, the more, we're kind of building on saying, look, it's this big mess that we got to kind of figure out. And so that's why it's difficult for someone working on, one-on-one with someone, that doesn't have that added sort of training can get lost. So we'll talk about some of these common vestibular disorders. So I want to talk about the mechanical issues, that BPPV, which stands for benign paroxysmal positional vertigo. And so what typically occurs is people will complain of this brief sort of transient or temporary vertigo that occurs. And why it occurs is because those otoliths, those crystals that are typically in the utricle and the saccule, get displaced out of there and kind of fall into the semicircular canals that where they shouldn't be, and those otoliths will typically bounce that cupula around and stimulate the eyes to move in a fashion that they shouldn't, and they get this dizziness. Typically, about 90% of the time, it will occur in the posterior semicircular canal. And the constant report that most people will say is, the world is spinning, something is spinning, my eyes are moving. And that typically occurs when they change position. So they're going, lying down, sitting up, rolling over or rolling their head over in bed. The other symptoms that they might really describe is, things like nausea, vomiting, feeling like they're off balance, lightheaded. They might get quite anxious or panicked when they're experiencing this, but it's temporary. Typically there's an onset of nystagmus, but this is really the most common cause of most dizziness. And so what we often see is that these individuals will have these episodes of torsional movement of the eye, where their eye is kind of going back and forth like that, and then it will typically go away within a few seconds, 20 to 30 seconds. They also might experience kind of a side-to-side movement. So we'll put them in some of these Finzel goggles, and we'll see the eye kind of going back and forth. And so it gives that sensation of the environment around them is spinning. And is typically often associated with some very strong symptoms. They might feel ill. Like I said, they might have an emotional response, feeling afraid or kind of panicked, because it's not a good feeling, and they feel fairly awful at the time. And then, so you might be having a client that you're working with, you might have them doing an exercise where they lie down on the mat, and all of a sudden they say, oh, I feel dizzy. And you look down on them and you see that their eyes are kind of moving in a different fashion. You go, oh, okay, yeah, we should probably send you to a vestibular therapist to get that checked out. So now, shifting away from the mechanical issue, if we have an issue that's more peripheral, these are issues that are affecting, again, the membranous labyrinth itself or the vestibular nerve itself. So some of the more common causes, labyrinthitis, neuritis, or even a labyrinthine concussion. What we're looking at is we're looking at a swelling, right? It's an itis. And so it could be coming from a trauma, like a concussion that actually bounces the inner ear around itself as well. You might have a virus that affects the nerve, so it would be a neuritis, or the labyrinth itself, so a labyrinthitis. And so this can cause dysfunction, and in an acute stage, that the spins that people will get in BPPV, well, it just keeps going. And so they might get, they might report that they have dizziness that is really, really severe for days and weeks, and you might not even see them in the setting that you're in if you're working in a gym or a rehab setting. Those of you that might work in case management, you might phone one of your clients and they have these, oh, I'm dizzy and I've been dizzy all day and it's just I can barely get out of bed. That's more of an acute sort of neuritis, labyrinthitis. We can also get these types of issues if they've, perilymphatic fistula, a little bit of a hole between the middle ear or the inner ear. We might see something like an acoustic neuroma, which is like a big growth, something that looks like that is actually causing compression on the vestibular nerve or the cochlear nerve, right? So we might get some hearing-related symptoms as well. You might get some sort of vascular issue, the small blood vessels within the inner ear. There might be some issue there. If there's more of a major trauma, a skull fracture, skull injury, or a pressure-related trauma can cause problems. And that kind of relates also to the idea of a Meniere's disease. And that's sort of a diagnosis that is through exclusion. These people that have these recurrent attacks of dizziness, what often it's attributed to is you have an increase in this fluid within the inner ear that causes increased pressure. And it's a confined space, so nerves don't like, to be compressed, and you get these attacks of dizziness that can occur from time to time. So, the big thing that we're looking for is as a vestibular therapist, is we're looking to see if someone has a loss of their VOR, their vestibular ocular reflex. So if the one side of if one ear has been affected with the vestibular nerve, we call it a unilateral loss. If both sides have been affected, it's a bilateral loss. Obviously, a bilateral is worse. But what we're looking for is, again, that loss of your VOR. So for those of you kind of logging in online, if you look at your computer screen and looking at me on the computer screen, and you slowly turn your head back and forth, does the image stay clear? If it does, then your vestibular ocular reflex is intact. If it's not, you might have a vestibular issue. So it's a loss of being able to keep your eyes fixed on a target while you're moving your head back and forth, okay? So typically, as you move your head back and forth, you want them moving in a 1-to-1 ratio. If I move my head one way, the eye should go the other way. If if there's a bit of a loss of that, we call that a slip, a retinal slip, and people can get some dizziness that occurs from, kind of the world. Ooh, something happened there. The brain interprets that. And that can feed into all those mechanisms that we talked about before. So your vision control can be off, your postural control and your balance can even be a bit off. And then finally, some of the common issues that can cause a central disorder, or things like a stroke or a transient ischemic attack, a TIA. And so those may cause damage to the brain itself, but we also talked about you can get some labyrinthine type concussions, you can get those types of things going on. Head injuries, things like degenerative changes like MS, so where the peripheral nerve connects in with the vestibular nuclei. There can be some difficulties with the demyelination that occurs with MS. And then finally, things like injury to the brainstem, cerebellar strokes, those types of things can obviously cause difficulties where the vestibular nerve is typically plugging into those centers. So typically people that are having more centrally related causes are going to have maybe not reporting dizziness so much as they'll complain of this disequilibrium. They might kind of feel like they're always leaning sideways, or you might observe them always kind of leaning sideways. Sometimes they'll get vertigo, but it's not as apparent. Just kind of going back with the peripheral issues, I kind of skipped over that. The typical things that people describe in a peripheral type issue are things like oscillopsia, so double vision or blurred type vision. Again, you might get some hearing changes, so a tinnitus or feeling kind of full in the ears. Vertigo itself, right, but it can be longer lasting, and it's not typically posture related. Balance can be affected, again, things like the nausea, the lightheadedness. So those types of things can occur with the peripheral issues. So you have this client, they're seeing you as a practicing kinesiologist, and they say, well, I'm dizzy. Well, you want to ask a few more questions, because you want to see, is this something that is more of an emergency that, I need to get this person some help, or is this something that, I more maybe just need to refer on to someone that has a bit more training? So, you can ask some questions about maybe some of their previous medical history. Do they have some history of cardiac events? Have they had some previous injuries like a concussion? Or maybe they have even had some known vestibular issues before. Oh yeah, I had these spins, the spins before I went to this guy and he kind of moved me around and it was fine. Okay, well maybe there's something going on. Are they having pain anywhere? Are they having neck pain? Are they having cardiac type symptoms, or are they having chest or arm pain? That's something that you're kind of like, okay, well, we need to maybe get this checked out a little bit quicker. Is it someone that's like, yeah, I actually have some underlying anxiety or panic type disorders? It can kind of guide you with, with what types of care you might be getting this person to look into. We refer to some of the more serious stuff, red flag signs. Are they seeing weakness? Are you seeing, are they complaining of numbness or weakness in their arm or leg? Are they getting dizzy, double vision? Maybe are they having difficulty speaking or swallowing? Those types of things, or are they having times where they're actually passing out? These are more emergency type situations where, you need to get this person some help ASAP because they're having some real difficulties. And also, is it something that's just come on all of a sudden, or is this something that they've kind of been living with for quite a while and it's just finally something that they're bringing to your attention? And then when they say their dizziness, try and tease out, what do you mean? Like, okay, well, the room is spinning. Okay, that's a vertigo. Are they feeling off balance? Are they feeling lightheaded? What does that mean when they're saying that they're dizzy? Are they getting some of those secondary symptoms of nausea, vomiting? Are they getting some visual changes? Every time I move my head, my vision goes blurry for, a second or two. Okay, those aren't really things that, are normal. Hearing changes. Okay, I have a ring in my ears that's kind of been going on for a while. And again, they might be getting some headaches, some neck pain, some jaw pain, and say, is this normal for this client that I'm seeing based on, what they're seeing you for. What triggers their symptoms? If it's more postural related thing, okay. And all this is information that can be helpful if you're sending this person on to a professional. You can send a note saying, hey, I have this patient. These are the types of things that when I ask them, this is the information they're giving me, and that just helps the treating physician or the vestibular therapist to make a better decision about how they're treating the person. And then eye prescription. I usually will ask, have you had any change in your vision or any change in your glasses prescription, those types of things as well. So you have your client, you say, okay, there's definitely something going on here that, I have questions about, I'm not really sure. I'm going to send this person on, but who do you send them to? Well, there's a whole team of people that could potentially be treating this person. So anything from physiotherapists, and we're typically one of the frontline people sort of seeing some of these people maybe initially. Neurologists or otologists, which are ear doctors, they might be able to provide some assistance in that. Neuro-otologists or neuro-ophthalmologists, which are eye doctors that are trained in neurology as well. So they can be a really good resource for these clients to get some care, and then they might actually send them to a neurophysiologist as well to look at some tests to test the function of the vestibular nerve and how that relates to vision as well. So there are some neurophysiologists out there that do this type of work. But if you're not sure kind of where to start, one of the things that I like to recommend is accessing the Find a Physio resource on the Physio Association of BC website. And you can actually go online to bcphysio.org and you can actually click on their Find a Physio link. And there's actually a drop-down menu where you can search for vestibular therapists, and they'll even break that down based on what city you live in and whatnot. And you can bring up the appropriate professional that you could actually send your client to. And these days we all have our smartphones. Well, there's an app for that. There is a Find a Physio app as well. So I mean, I know I'm plugging my own race here, but there's lots of trained professionals. A lot of time depending on where you're working, you might already have access to a physio that's in your clinic that you might be, if you're in a multidisciplinary team, or if you have access to these types of things. So it's important to have those connections and to communicate, because we're not working in silos anymore. It's there's a lot of shared care for a lot of these individuals. So you find someone that you're going to send your client to, and the client's going to start, well, what is this? What are you sending me to? So it's what are they going to do to me there? So it's good to have a basic background of or an understanding as a kinesiologist what your client might be going through. So typically a vestibular therapist is going to go through again that medical history and that vestibular history, ask some of those same questions, but they'll probably also ask some more pointed questions about some of the medical history and try and tease out what exactly it is that they're dealing with. There's typically going to be some assessments, more of a safety assessment of looking at the stability of the cervical spine, of the blood vessels that are coming up through the neck, and seeing if the individuals are safe to go through a vestibular assessment. And they'll also do a real thorough assessment of the neurological system and do a bit of a screen, just to make sure that there's nothing more sinister going on. Because like I say, the symptoms that someone can present with are this kind of gray mess of subjective symptoms that we're trying to kind of tease out what's going on. And then they'll do some specific objective tests looking at, is it a mechanical issue, is it a peripheral issue, is it a central issue? So for things like BPPV, what we're looking at is we're looking to see, are there the presence of those otolith, those little crystals in the semicircular canals? And so what they'll do is they'll go through a couple of tests called the Dix-Hallpike maneuver or the supine head roll test, where we're moving the person around, so lying them down, sitting them up with their head in different positions, just to determine if moving these crystals around causes the dizziness to come on. And if it does, then we can go through some treatment for these individuals. And so typically it's an activity called a modified Epley maneuver or a horizontal canal repositioning treatment. So we're floating these crystals back into the component of the inner ear, into the utricle, where they need to be. And typically these people do really well. So within 1 session, 2 sessions, we can actually clear those crystals out, and these people's dizziness will actually go away. In about 25% of the population, it can recur in about a year, but a lot of the time these people do quite well. They get over that bout, and away they go. Now, if it's more of a peripheral issue, typically the therapist is going to be looking at that VOR, that vestibular ocular reflex. Is a person able to maintain their gaze stability there? And also looking at, assessing their balance, assessing their ability to, maintain their body in space. They might look at posture as well. So typically what they're looking for is, they'll kind of be moving the person's head back and forth and seeing, can they keep their eyes on a fixed target? Now, treatment for that typically takes a bit of a long, it's not a 1 session, 2 session thing, and usually can occur over the course of anywhere from 6 to 12 weeks, depending on how severe the pathology is. And a lot of it will be involved with retraining that gaze stability or retraining the balance. And a lot of the time that's where the kinesiologist might collaborate with the treating therapist and be in contact with them as far as ensuring that those exercises are being done properly when they're out in the community working with the kin. And then the therapist will typically be prescribing those exercises to the client with very specific recommendations, and then also hopefully relaying that on to the kin as well. And then centrally, if they're thinking that it's more of a central issue, something to do with the central nervous system, they're going to be looking at what's this person's eye control like. They'll also be, of course, looking at that VOR and the balance. So there's some overlap in those, but they're looking at, okay, what's this person's eye control like? What's their postural control like? And wherever the deficit is, that's where they're typically going to be working on. So some specific drills to address those deficits. And they might even be looking at things to habituate the person or get them used to that dysfunction. If you have someone that's coming in and they're maybe a couple years after a stroke and they're still having some dizziness symptoms, well, we work with them for a bit, but if they're not making significant changes, it might just be getting them used to dampening down that response from the nervous system to try and make it more comfortable for the person, or knowing what things to avoid as well. Okay. So kind of brings us to where do kinesiologists fit into that? And quite often, I've had clients come in and they're actually working with a kinesiologist out in the community after their head injury or after their MVA. And they come and they say, well, I'm working with this kinesiologist. And so you guys are typically having a lot of access and input into what this person's doing and how they're doing it. So you can play a really, really big, important role in what the person's doing day to day and how they go about those exercises. So everyone is going to be different that's presenting to the vestibular therapist, and so their treatment is going to be different. So you really have to have an open line of communication between yourself and the therapist, because they're going to be looking to you to monitor some of those exercises that were given by the therapist and maybe making some corrections on their posture or how they're doing those things, or telling you when it's appropriate to be progressing them along and how they want that to be going. So it's really important to have that open dialogue. Myself, when I'm sending a client out with those problems, with a vestibular issue, and I know that they're working with the kin, I'll typically send a note along to the kin or try and contact them saying, look, this is what I'm seeing. These are the types of exercises that they want to be doing, and and this is how I want it to be progressed, because we're looking for specific things. So just as an example, this is just one example of one balance sort of progression that I might do with someone that is everything is safe, we've checked everything out, they're stable, but they have a bit of problems with their balance. So what we might look at is having the person kind of stand with a narrower base of support and see what are they like with their eyes closed. We take out that visual fixation of their environment and just kind of rely on the vestibular system itself, as well as their feedback from their joints, and see, can they master that for 30 seconds, repeating that a few, times. Okay, can we progress that to doing that on a single leg, right? Can they then progress that to doing that in a tandem stance? And once they've mastered each one, for 30 seconds as an example, maybe then that's an appropriate time to progress that along. And then you can make it more difficult. So we might have the person standing on a piece of foam so that it's not quite as solid of a surface, and progressing along. So you want to do it in a stepwise fashion. And again, that's going to just depend on where the person's at, what level they're starting at. And so if you're not sure, I typically be deferring to that vestibular therapist that they're working with and saying, okay, what is it, where can they start, when is it, what are you working on, and when is it appropriate to be progressing along in that regard, okay? So it's not just throwing exercises and hoping that they stick, okay? The other thing we talked about was gaze stability exercises, and again, this might be because the vestibular therapist was finding that their eyes were kind of not tracking particularly well when they're doing some of the gaze stability tests. So where they start depends on the level of the person on their assessment. So again, you got to talk to the therapist and have that open line of communication. But they might start kind of looking at a target, nice and slowly moving their head back and forth, and then they might increase the speed that they're doing that at. You might change the surface that they're on. So if they're sitting, you might have them up into a standing position. You might change the background that's behind there to something that might look more like that, right? So it just depends on the situation. But it kind of brings the next point up, that when you're considering the exercises that you might be giving the person as part of their rehab program or their exercise program, if you're working in a client in that setting, you really just have to be aware of the safety components of someone that has some dizziness, right? So if you have someone where certain positions are a trigger for them, you might be avoiding them going up and down, or looking up and down, or rolling side to side as part of their program, right? If you're doing someone in a plank and you get them rolling on their side and they get dizzy, well, you might need to modify what you're doing in that regard. Busy environments, so things where there's lots of bright lights or a lot of patterns, or just really busy, like a really busy gym atmosphere, right? After work, the gym's full. The person might not tolerate that, depending on the issue that they're having. So you just have to take that into account, and be talking with your client, saying, okay, what is it that seems to be bothering you? Or if you're on the phone with the vestibular therapist, and they're saying, look, this is kind of what we're seeing. We go, oh, okay, we might need to modify, get them out of that busy area, and maybe getting them into a quieter area that's more appropriate for them. And then the exercises themselves are specifically, to try and optimize some issue. So be it balance, be it gaze stability. And you want to set the client up for success. So if you're having them doing balance drills, making sure they have a surface to go onto, and they're really focused on the task at hand, and not progressing them too quickly along that. I think it's real easy for us to try and say, okay, we want to really get this person up onto that Bosu ball and getting them balancing, and really if their neurological system is not coming together and doing well during that time, they're going to have a hard time progressing along. So, we're dealing with the nervous system. It's not a muscle. It's not a ligament. It's not something that's going to respond quite as quickly. So it can take a long time to retrain that nervous system. Now, that being said, if the person's been medically cleared and they've been assessed by the therapist, and we're saying, it's safe to go ahead with a lot of these exercises, you might just need to keep these certain things in mind that we talked about earlier as far as the location and whatnot. You can go along and continue to do a lot of these activities because they're really important for the person's general health as well. So things like core strengthening, resistance training, cardiovascular, all that kind of stuff, it can be integrated into the program, without too many issues. You just have to look at, where these triggers are really coming into place. So that kind of brings me to the end of the talk itself. So hopefully, in the past sort of 45 minutes or so, I've had the opportunity to teach you something about what the vestibular system is, what its function is, and how pathology of the system can affect your clients and what that might look like, and then also how to refer these people onto the appropriate treating therapist so that they can assess and treat these guys and provide you the information that you need to do your job as well. And then how you can also work together with the vestibular therapist to monitor these clients and progress them along in an appropriate way so that they're getting the best possible care over the longer term. Okay, so I'd like to thank you all for coming out today, and for those of you online that are logging in. And we got some time for some questions now, I think. So, whenever ready. Okay. So the question is, my 80-year-old client has poor balance. I did the Berg test and she collapses if she closes her eyes. It seems worse if she closes her eyes and holds the counter with her left hand compared to her right. She wears hearing aids. She walks unevenly and feels like her balance has changed recently. I have suggested she see her doctor about it, but I am wondering if there is another professional I should send her to. We are in a small town and may not have access to many therapies. So it definitely sounds like she's having some difficulty when she's closing her eyes. Now, 80 years old, we know that as people age, our general sense of balance will tend to deteriorate over time. This is where I would send this person for a vestibular assessment if possible, just to try and differentiate if this is someone who just generally has poor balance. Because we got to remember, our sense of balance is based on a few things. It's going to be based on our proprioceptive input from our joints. It's going to be based off of our visual feedback as well as our vestibular system, right? So if you've got deterioration in any of those three, and then we take one out of the mix, it's really going to kind of accentuate where you might be having problems. So if the eyes are closed, we're really relying on the vestibular system as well as our proprioceptive system to give us feedback. So if there's other symptoms that she's having as well, and because it's a recent change, it might be prudent to follow up to get a further evaluation of what's going on, just to suss out if that's something that's more truly just an age-related change, or if it's a change in the vestibular system that we could be work on, with some training on for sure. Yeah, good question. Yeah. Yeah.
In your experience, how effective is that comparison to just normal balance tests or other tests that you can do more simply?
Yeah. So in a lot of the larger, so the question was, for those that didn't hear, was about a computerized balance test essentially. So it really depends on the center. I think that they're a great tool, and you can definitely, especially if you're doing assessment and then subsequent follow-up, you can often see differences with training a person's balance and those sort of things over time. So I think that they're a good tool. A lot of these machines are quite expensive, to be quite honest. So they're great resources to have, and they're useful. A lot of the time, we're looking for small differences in a person's balance within the clinic setting. So doing something simple like a Romberg test, where a person might have their feet together, eyes are open, you're looking at how their postural stability is, and then closing their eyes. If they start really coming up, you're going, okay, that's probably not a normal response, especially if you're looking, this kind of refers to the previous question, if you're looking at someone that's in their mid-40s and they close their eyes and they start falling over to one side, you're saying, no, well, that's not a normal kind of response. So we can get a lot of information clinically just with some very basic tests, but a lot of the time, if someone's having more of a major issue, I might even refer them on to a dizziness clinic or a vestibular clinic, where they might have some of the more computer-related posturography measurements that can then give us maybe a more specific number, and it still relates to seeing some dysfunction in there for sure. Yeah. Oh, so we have another question here. So I work in a concussion clinic, and many of our clients have complaints of dizziness stemming from their concussion. What is the most common relation between vestibular issues and concussion? That's a tough one. So I recently took a course on vestibular rehab in concussion, and what they're seeing more and more is with a concussion, we're seeing a lot of dizziness-related issues, and it makes sense that those are occurring, because when you have a trauma, a sudden impact or a twisting type mechanism to where most concussions occur, you have the brain that's going to be moving around within the skull, but you have this soft little vestibular membranous labyrinth that's sitting within the skull, and it's bouncing around as well. So again, you might be seeing signs of a peripheral issue that could be going on, but centrally we know that there's one of my colleagues has been doing a lot of work in concussion as well, and one thing that he's noticing is that people's ability to track moving objects can be affected, and so we would typically think that that's more of a central related issue, so that can be with an injury to the brain or the brain stem itself that can be affected, but all those connections into the vestibular system can be affected as well. So there's definitely some overlapping both in concussion and in causing vestibular issues. Next question, I have an ICBC client 2 years post-accident. She reports dizziness, headaches, and pain in her neck. The dizziness has been caused her to fall on occasion. She had an MRI and has seen an ear-eye specialist, which gave normal results. Any thoughts? Yeah, so a lot of time with something like a concussion, results on an MRI will be normal. So typically if there's results, they're not calling it a concussion, they're calling it a brain bleed or something that they're able to see. Can you pull that? Okay, thank you. Yeah, so it's not uncommon to see that. Depending on the ear and the eye specialist and their training, they may not go through some of the assessments for vestibular dysfunction. They might think that there's something going on, maybe in the inner ear, but a lot of time I'll get a referral from an ENT saying, hey, can you take a look at this person, because they know that there's probably some sort of vertigo-related issue going on, but there's some difficulties with that. Yeah, and then there's one other question here. Is there a certain population where you see an increased incidence of vestibular issue? For example, what is the average age of the clients you work with? Does BMI play a role? I work with individuals who have obesity and have balance issues already due to their smaller walking gait and other mobility issues. They also complain of symptoms of dizziness, nausea, dysphagia, but also have weight-related comorbidities such as diabetes and hypertension. What questions would you recommend incorporating into our medical history screen to help assess them for vestibular issues? So that's tough. I mean, there's when we're looking at comorbidities, we know that age, there's an increased incidence of vestibular problems as we age. Some of the things that you're talking about as far as BMI and some of these are going to be more conditioning, conditioning and more so deconditioning related issues. So as far as questions in the medical screen, I think some of those basic questions like when are they getting dizzy? Is it something that if they're having cardiac related issues or if postural hypotension seems to be kind of more the issue where they sit up and they're dizzy for a few seconds, but it's not that same kind of spinning. I think you just have to be asking questions more specifically about the dizziness that's occurring, and if it sounds like they're getting posture related issues or their dizziness is of something more profound, that will kind of guide you into maybe referring to a vestibular therapist. And it's also hard to know, some of these questions are coming in. If you're in a multidisciplinary clinic and maybe have access to referrals for a therapist to come in, that can also be helpful as well. So it's one of these things that's a gray area that it's hard to pinpoint what exactly is going on. Is there evidence that supports the use of the VRR testing is safe for all people who have sustained a neurological central injury, specifically tests where the head is shaken? Yeah, so VRR testing is not safe in all populations. So that's why prior to going through a lot of these tests, we're taking precautionary steps to try and assess a person's cervical stability, their vertebral artery function, their neurological status, medical history, to ensure that before we are even touching this person and going through some quick type head shaking movements, that the person is safe to do so, right? And also getting the person's consent to go through some of these tests, because as we're going through some of these objective tests, there's going to be risks associated with that and contraindications to that. So in a lot of cases, if someone's presenting to me and discussing that they're having some of these underlying issues, I'm listening for certain things as far as how they're moving their head and the symptoms they get, and I'm saying, well, I'm really going to send you back to your doctor and we're going to get some imaging done to check that your bony stability and your vascular stability is intact before I go ahead and go through some of these tests. Do you know of any further educational courses someone can take in this area? Daryl and I were discussing this earlier. So a lot of the time, these courses are going to be open to certain populations of professionals. So, physios, physicians, chiros. As far as I know, there's not a lot open to kinesiologists themselves. That's kind of why we set this up for today, is to provide some information about, at least, you're working on the front lines, you're recognizing some of these people that have some issues. It's trying to move them along to someone that might have some extra training in that. You can definitely look into information to educate yourself more about it, but as far as coursework, not that I'm aware of.
Yeah, Farron, thanks for that. I was going to say there is also the avenue you can take where some of the testing, where you can go through the concussion clinic training. That may be something you can discuss as well.
As far as
Some of the tests they do for concussion. Like kinesiologists are often involved in concussion testing.
yeah. So not really it's not really my area of expertise, but yeah, there's a number of concussion tests, the King Devitt and some of these more posture related tests, and that a kinesiologist can be involved with, especially in that population. And there is some overlap. There is some overlap that can occur as well with vestibular dysfunction. So you might pick up a little bit on that. And as you're working in those fields, typically you're going to come across people that are involved in vestibular therapy as well. So it's maybe discussing them and educating yourself as you're working with those individuals. What to look for and treat in a client with complete deafness unilaterally. It depends on their symptoms. A person can have some deafness for a number of reasons. It depends on what they're complaining of. If they're complaining that maybe their environment is, as they move their head around, they're getting blurred vision or things are jumping around. Maybe on that same side, if they're having some deafness, maybe there's some loss of vestibular function that they're picking up on, or that they're. So I think that in that case, yeah, if they're complaining of some symptoms of dizziness or blurred vision, or double vision, or things kind of jumping around on them, it'd be worth sending them along to someone. Is there any resources that would outline standardized exercise progression for different vestibular concussion-related problems and deficits? Again, no. It's going to be based on the presentation. So, there's not an exercise book I can send you, say, oh, these are all the vestibular exercises you are going to prescribe, because again, the person might have dizziness. Well, you go to a book and you start prescribing exercise. Well, the person might have an underlying, cervical stability issue, or they might actually be having more of a blood flow related issue. So I think you're getting yourself into a little bit of trouble if you're starting to just, prescribe exercise. So there's not any specific one. Again, you have to refer back to, getting an appropriate assessment, and then the treatment will be based on that, and communicating with the therapist as far as what's appropriate. Is the PowerPoint presentation available online? Well, this lecture will be. I can make those slides available online afterwards as well. Yeah. I've had a client post-treatment for vestibular therapy leave so that she had to be walked out to her taxi, and then the driver had to assist her to the door. Does this indicate overly aggressive treatment? That's hard to answer. So yes, a lot of the time when a client, and this is probably a really important point. So if you're sending a client to a vestibular therapist, some of the tests will could or will bring on some dizziness. Typically, the people are feeling better by the end of their session, but depending on how the person responds to the assessment, I've had clients where I go through an assessment, we've checked everything out, everything is safe, and we have them lie down, and they definitely have like BPPV, but they have such profound dizziness that they start to feel ill. They just they're feeling quite poorly afterwards, and so typically I'm warning people ahead of time, saying, look, you might feel dizzy. Make sure that you have a family member that can drive you to the appointment and backwards, because when we stimulate that dizziness in some people, that can take a number of hours to settle down, because we've stimulated their nervous system and they just have a very profound response to that. So it's it can happen, unfortunately. So if you are talking with your clients, just make them aware that you might get dizzy, or you likely will get dizzy at some point during the assessment, and everyone kind of responds a little bit differently to that. It's not that it's the person's unsafe to do that, to bring on that dizziness, but Yeah, no, I've had a couple clients that have gotten, you know, fairly dizzy, fairly ill feeling in the clinic. So, yeah. All right, I think that's the end of the questions, and thanks a lot for everyone logging in today and in the lecture today, and hopefully that information is helpful.
Thank you very much, Farron.
You're welcome.